Dear colleagues, let's get it started. Okay. So, today we have a lecture and it's dedicated to perioperative medication in adult cardiac surgery. So I will introduce myself. I'm Michael V. Ilyin, MD, PhD. I'm a head of the Eugen Nikolaevich Dormidontov Department of Therapeutics of Yaroslavl State Medical University. And first of all, I would like to declare the absence of conflict of interest. So no pharmacy. It's clear, absolutely. And this presentation is based on the 2017 EACTS guidelines on perioperative medication in adult cardiac surgery. It was developed by the task force of the European Association for Cardiothoracic Surgery, EACTS, and it was published in European Journal of Cardiothoracic Surgery in 2018. And in the beginning, I would like to remind you some levels of evidence and classes of recommendation. And you remember that level A of evidence is based on the data derived from multiple randomized clinical trials or meta-analysis. Level B, data derived from a single randomized clinical trial or large non-randomized studies. And the third one is level C, the consensus of expert opinion and or small studies, retrospective studies and registries. And classes of recommendations, you know, there are three classes. Class 1, evidence and or general agreement that a given treatment or procedure is beneficial, useful, and effective. It is recommended and is indicated. Class 2, conflicting evidence and or a divergence of opinion about the usefulness, efficacy of the given treatment of procedure. And it is divided into two classes. Class 2A, weight of evidence, opinion, is in favor, or usefulness, efficacy, should be considered. Class 2B, usefulness, efficacy, is less well established by evidence, opinion, and may be considered. And class 3, it is absolutely, is not recommended, Evidence, general agreement that the given treatment procedure is not useful, not effective, and may sometimes be harmful. So we said it. And now some abbreviations. I'm not planning just to read it over, but I would like to stop on some abbreviations. For example, ASA, you know, acetyl salicylic acid. Okay? CABG, or cabbage, like our colleagues say, coronary artery bypass grafting. DAPT, dual antiplatelet therapy. LMWH, low molecular weight heparin. And this is interesting, NOAC, non-vitamin K antagonist oral anticoagulant. Not a new oral anticoagulant, you know. And two more, UFH, unfractionated heparin, and VKA, vitamin K antagonist. They're most widely spread abbreviations in my presentation. So let's go to the preamble. In the preamble, I would like to say that medical therapy affects adult cardiac surgery at three distinct stages: preoperative, intraoperative, and postoperative. Preoperatively, one might need to introduce or interrupt drugs to decrease the odds of procedural complications. On the second stage, intraoperatively, control of glycemia or prophylactic antibiotics are essential to reducing the risk for infectious complications. And third, postoperatively, This is very important. Restarting or initiating medication to prevent ischemic events, prevent arrhythmias, and manage cardiovascular risk factors in heart failure is required to impact the long-term prognosis in a positive way. This is very important, you know. Antithrombotic treatment we are discussing today with anticoagulants and platelet inhibitors reduces the risk for thromboembolic complications, but may increase the risk for intraoperative and postoperative bleeding complications. An individual assessment of the risk for thromboembolism and bleeding based on the medication, patient condition, elective, urgent, or emergent, imaging results, and planned surgical intervention is recommended within the Heart Team Conference. So here we meet a new term, Heart Team, because Heart Team get together different specialists, cardiologists, cardiac surgeons, anesthesiologists. That is why we get together in this beautiful hall today. And one recommendation, Class 1, Level C, it is recommended that the Heart Team discuss the optimal timing of stopping antithrombotic preoperative treatment of patients undergoing cardiac surgery based on ischemic and bleeding risk. So we realize multidisciplinary decision making. This is very important, you know? Okay, you got it? Very good. So follow me. Okay, so we have different classes of drugs. I'm planning to discuss today platelet inhibitors, you know them, acetyl salicylic acid, platelet receptor P2Y12 inhibitors, clopidogrel, prasugrel, ticagrelor, cangrelor, and GB3A receptor inhibitors, abciximab, eptifibatide, and tirofiban. And also anticoagulants. They are divided into two parts, indirect and direct. Indirect anticoagulants, vitamin K antagonists, warfarin, and NFH, low molecular weight heparin, and fondaparinux. And the last one has a very specific clinical pharmacology we have to take into account before we prescribe fondaparinux, because there are 17 hours of half elimination of the drug. That is why it is not recommended in the long-term treatment, okay? But we will discuss it later. Direct anticoagulants, thrombin inhibitors, dabigatran ethoxylate, and factor 10A inhibitors, rivaroxaban, apixaban, and edoxaban. Okay, let's go, and we will discuss several of the drugs. And we start from the acetyl salicylic acid. It's widely spread, prescribed medication. What about acetyl salicylic acid? In a large prospective observational trial, patients who restarted ASA within 48 hours of CABG had a mortality rate of 1.3% compared with a rate of 4.0% among those who did not receive ASA during this period. And when we use and prescribe ASA therapy, it is associated with, look at these digits, 48% reduction in the incidence of myocardial infarction. Statistically significant. A 50% reduction in the incidence of stroke. 74% reduction in the incidence of renal failure. 62% reduction in the incidence of bowel infarction. And all of these data is statistically significant. A systematic review of 7 studies showed that administration of acetyl salicylic acid within 6 hours of CABG was associated with improved graft patency without increased incidence of bleeding complication. That means that ASA should be given to all patients having CABG as soon as there is no concern over bleeding, before surgery and after surgery. This is important. Okay, you got it. I see. Then let's look to the recommendations. What recommendations say about acetyl salicylic acid management? And we are discussing the first stage, preoperative. First of all, I would like to show that bridging oral antiplatelet therapy with low molecular weight heparin is not recommended. So we do not need to cover acetyl salicylic acid with heparin. No way. Okay? In patients on ASA who need to undergo CABG surgery, continuing ASA throughout the preoperative period should be considered. 2AC. Stopping ASA at least 5 days before surgery should be considered in patients who refuse blood transfusions, undergo non-coronary cardiac surgery, or are at high risk of re-exploration for bleeding. TAC. Postoperatively. So, what we can see with acetyl salicylic acid management after a surgery. It is recommended to restart ASA as soon as there is no concern over bleeding, but within 24 hours of CABG. So we get it back after surgery immediately. 1B, level of evidence. In patients undergoing non-coronary cardiac surgery with a preoperative indication for ASA, it is recommended that treatment is restarted as soon as there is no concern over bleeding, but within 24 hours after surgery. 1C level of evidence. The next group is P2Y12 receptor inhibitors, receptors of platelets. So, preoperatively, you see the logic. Preoperatively, postoperatively. So the second group, preoperatively. In patients on DAPT, double antiplatelet therapy, who need to undergo non-emergent cardiac surgery, postponing surgery for at least 3 days after discontinuation of ticagrelor, 5 days after clopidogrel, and 7 days after prasugrel should be considered. So you see, 3 days for clopidogrel, for ticagrelor, 5 days after clopidogrel, and 7 days after prasugrel. Why is that so? It's because of pharmacokinetics. Because of the time of half elimination of the acting substance. Okay? Platelet function testing may be considered to guide the decision on the timing of cardiac surgery in patients who have recently received P2Y12 inhibitors. This is very important because in our routine practice we do not do so. We do not do. And that's the way to some new methodology for decision making. This is important for practical doctors. And the third one, bridging P2Y12 inhibitors with GB3A inhibitors or cangrelor may be considered in high ischemic risk patients. So you see the double antiplatelet therapy. Very interesting. Postoperatively, in patients treated with the APT after recent coronary stent implantation within 1 month who subsequently undergo cardiac surgery, it is recommended to resume the P2Y12 inhibitor postoperatively as soon as there is no concern over bleeding. So we get them back after surgery if we have a situation with stenting before a surgery and after surgery. So we get it back. In patients treated with DAPT after coronary stent implantation exceeding 1 month, or ACS, acute coronary syndrome, without stenting, who subsequently undergo cardiac surgery, it is recommended to resume the P2Y12 inhibitor postoperatively as soon as there is no evidence or no concern or bleeding, but within 96 hours of surgery, and continue DAPT until the recommended duration of therapy is completed. Dear colleagues, the rector of the Yaroslavl State Medical University, applause. Welcome. Dear Alexander Leonidovich. Okay, DAPT may be considered after CABG in selected patients with stable CAD, coronary artery disease. This is a very rare situation when we perform endarterectomy, but it could be, and off-pump surgery, but off-pump is pretty widely spread. Okay. The next group is GB3A Inhibitors. Let's see what we're gonna do now. Antiplatelet therapy with GB3A inhibitors, abciximab, eptifibaptide, and tyrosine are almost exclusively used in conjunction with percutaneous coronary intervention. Percutaneous intervention, but may also be used for bridging high-risk patients taking oral P2Y12 inhibitors to surgery. The optimal time delay for discontinuation before surgery is based mainly on pharmacokinetic assumptions. Platelet function recovery is obtained within 24 48 hours of discontinuing abciximab. This is important. And up to 4 to 8 hours after discontinuing eptifibaptide and tyrosine. In addition, other clinical studies suggest that cessation 4 hours before surgery is sufficient for all GB2B3 inhibitors, including abciximab. So the recommendation, class 1, level C, it is recommended to discontinue GB3A inhibitors at least 4 hours before surgery. That means that the day before a surgery, the patient receives this drug. Okay? Very good. The next large group of medications are anticoagulants. So, what do we know from recommendations about oral anticoagulants management? Preoperatively, as before. Preoperative period, it is recommended that vitamin K B antagonists be discontinued 5 days prior to surgery to aim for an INR, INR, international normal ratio. Yep, МНО. INR это МНО. 1.5 on the day of the elective cardiac surgery. And you see a very high level of recommendation, 1C. For patients on non-vitamin K oral anticoagulants preoperatively, discontinuation of therapy is recommended at least 96 hours prior to surgery, depending on renal function and the agent. So we see that we have to take into account the renal function, and the state of the patient. That means and the agent. Okay. Bridging of OAC is recommended in patients with any of the following indication. Note here, this is important. First, mechanical prosthetic heart valve. bridging. The second situation, atrial fibrillation with moderate to severe mitral stenosis. The third one, atrial fibrillation with CHA-DS VS score more than 4 points. More than 4 points. So we have to count before we make a decision. And the fourth one is acute thrombotic event within the previous 4 weeks. So in these 4 situations, we need a bridging. You got it. Then preoperatively, it's very good bridging with unfractionated heparin, but I would like to stop on the bridging with fondaparinux, which is not recommended. Class 3, level C. Why not? Because of pharmacokinetics. 17 hours, the time of half elimination. We do not have so much time to work with it, to stop it. That is why recommendation is not recommended. Okay. And post-operatively, so we are successful, we performed the surgery, we did it. Now what are we gonna do after surgery with oral anticoagulants? In patients with an indication for post-operative therapeutic bridging, it is recommended to start unfractionated heparin 12 to 24 hours after surgery. This is very important recommendation. If not, low molecular weight heparin should be considered as an alternative bridging strategy to unfractionated heparin 24 to 48 hours after surgery. But I have to say that we use unfractionated heparin wrongly, in a wrong way, because we do not need to infuse it subcutaneously. We have to use some dosage pump, the infusomat. Okay? It is recommended to reinitiate vitamin K antagonist warfarin on the first post-operative day, 1C. On the first post-operative day. We have to get it back. Delaying the restarting of non-vitamin K oral anticoagulants for 72 hours after surgery should be considered 2AC. And also post-operatively, no ACS are not recommended in patients with a mechanical valve prosthesis. Not recommended. Why? Because we have to prescribe warfarin. That's the recommendation. And also I have to say that these recommendations were published in 2018. So we're waiting today for the renewal, for new recommendations, new guideline. And we see it already concerning the non-cardiac surgery. We'll be waiting for the next generation of recommendations. But today, it's the following. Then, the addition of low-dose acetyl salicylic acid within 75 to 100 milligram daily to vitamin K antagonists should be considered in the case of concomitant atherosclerotic disease. This is interesting. Aspirin and warfarin at the same time, 2AC level. And the addition of lifelong low-dose ASA, 75 to 100 milligram daily, to VKA should be considered after thromboembolism despite an adequate INR. Despite of adequate INR. Very interesting. What about mechanical prosthesis? We have to prescribe lifelong low-dose acetyl salicylic acid in addition to vitamin K antagonists, and they should be considered after thromboembolism despite an adequate INR. So we prescribed warfarin, we did it, and we got normal level of INR, and despite of that, we prescribe acetyl salicylic acid. Triple therapy. This is very hesitating situation. Triple therapy comprising vitamin K antagonists, aspirin, and clopidogrel should be considered for a duration of 1 month after acute coronary syndrome or recent stent implantation followed by vitamin K antagonists and low aspirin or clopidogrel, 2AC. And finally, INR, international normalization, self-management is recommended provided that appropriate training and quality control are performed. So we have to control the situation very thoroughly. Bioprosthesis. Oral anticoagulation is recommended on a lifelong basis for patients with surgical or transcatheter implanted bioprosthesis who have other indications for anticoagulation 1C. Oral anticoagulation may be considered for the first 3 months after surgical implantation of an aortic bioprosthesis. And low dose of aspirin should be considered for the first 3 months after surgical implantation of an aortic bioprosthesis or valve-sparing aortic surgery. And oral anticoagulation using VK should be considered for the first 3 months after mitral or tricuspid valve repair or bioprosthetic valve replacement. Very interesting situation with TAVI, TAVI. You know what is TAVI? Yep. Okay. DAPT. Yeah, TAVI. This is a very popular procedure today. Pretty expensive, but very interesting. It's low invasive procedure. No open heart. Okay. DAPT should be considered for the first 3 to 6 months after TAVI, followed by lifelong aspirin in patients who do not need oral anticoagulants for other reasons, 2AC. And aspirin monotherapy may be considered after TAVI in cases where there is a high risk for bleeding. You see, when we perform a TAVI, we prescribe only aspirin. Only aspirin, no oral anticoagulants in case of a high risk for bleeding. And other indications in patients undergoing cardiac surgery with a preoperative indication for oral anticoagulation, it is recommended that the preoperative regimen of VKS or no OACs be started after surgery. And finally, I would like to give you an algorithm of perioperative anticoagulation and bridging. Let's discuss it very thoroughly. This is important. On the left branch, you see here, it's the branch for VKA, vitamin K antagonist. That means warfarin. So what are we gonna do with warfarin before and after surgery? Let's see. First of all, we have to stop vitamin K antagonists 5 days before intervention. Stop warfarin 5 days before intervention. 4 days before surgery, we have to start unfractionated heparin or note therapeutic dosage of low molecular weight heparin. Therapeutic, non-prophylactic. It's bridging therapy. But we can stop with warfarin, but not start with heparin. Why? Because we're waiting for normalization of INR until 1.5. That's normal. And if we are on the point of a surgery and we have INR 1.5, it's okay. No problem. Okay, if not, we have to stop unfractionated heparin 6 hours before a procedure. But low molecular weight heparin, we have to stop the day before a surgery, because of pharmacokinetics. So, the day of intervention, and everything's gonna be all right. We have great surgeons, good heart team, wonderful anesthesiologists, and we did everything brilliant. So, the patient is alive, and we are starting to work with him. We have to restart unfractionated heparin 12 to 24 hours after procedure. And the day after, we have to restart warfarin to cover and then to control the INR every day until we reach the point, the goal INR, and limits 2.0, 3.0. For different valves, it may be different. Okay? Then we have to switch to low molecular weight heparin or to continue unfractionated heparin, but this is our decision, as you wish. And finally, we stop heparin 4 days after intervention, reaching INR 2.0 for aortic valve or 2.5 for mitral. And after, the patient goes with warfarin. So this is the left branch. And look at the right branch. Non-vitamin K oral anticoagulants. This is more simple. More simple. We have to stop NOACs 2 days before surgery. And this is all. So it's not difficult. And after intervention, we have to start UFH 24 hours after procedure. And 2 days after, we have to switch to low molecular weight heparin or continue unfractionated heparin. In 5 days after intervention, we have to restart NOAC and stop unfractionated or low molecular weight heparin. This is all. So that's the main scheme. What we're gonna do during the perioperative period concerning anticoagulation and bridging. This is a very simple scheme. And finalizing today's very short lecture, I would like to show you the algorithm for antithrombotics in valve prosthesis and valve repair. And I'm not planning to discuss the scheme because it is so you can do it yourself. Actually, this is your task for the next day, maybe. Okay, thank you for your attention. Thank you. Any questions? Друзья, это абсолютно рабочая вот, встреча по этой причине, пока вот Александр Леонидович к нам присоединился. Вот, слово Александру Леонидовичу.
Dear colleagues, thank you for attention. And according to our tradition, it's our first experience to conduct our English knowledge in practice, in lectures, because we are looking forward to involve much English students to our university. And it is a first step, and it's very interesting. Is everything clear, or you have some misunderstandings? Is it possible to maybe have some questions in English and also answers? And we'll be in this discussion, we have to be more clear for everybody that if you have some misunderstandings or some problems, you will be to announce them. It will be our mutual and maybe work how to involve everything in this process. Are there any some problems in English? Are there some maybe a decision how to resolve these problems? So we are everything. We are very open. We are very maybe open for every your comments, suggestions, and let's start our conversation. What questions do you have?
Yeah, please.
First of all, if we have the opportunity to discuss with Mikhail Vitalich some problems, this is a chance to maybe make discussion between therapeutics and clinical pharmacologists. So the first question is connected, what do you see about drug-drug interaction? Because the anticoagulants medicine is very high risk according to the pharmacovigilance aspects, safety, and the risk of gene polymorphism, according to the warfarin especially. So what do you see about this problem?
Thank you so much for your question. This is very important, the question about the interaction between anticoagulant drugs. And I would like to say that these questions are discussing in recommendations concerning the period, the time of the delay of the drug before a procedure. And that is why we are talking about, for example, P2Y12 inhibitors, receptor inhibitors, concerning the time of delete before a surgery, a stop before a surgery. As for interactions, I have to say that they could be dangerous. They could be dangerous because of bleeding complications. And this is very important to control laboratory values during the period of a surgery, like before a surgery, and after a surgery too. That's my answer. But of course, I'm not a professional in clinical pharmacology, but I do agree that we have to take into account some gene pharmacology. This is very important. And if we have a possibility to examine, that would be great. And I hope that in frames of our university clinic, we could do it in the future. That's my answer.
Okay, thank you so much for your answer.